in today's Virtual Rural Needs Action Summit. We have completed our introduction and session 1, and we are ready to dive in to session 2, idea sharing, what's being done. I am going to pass it on to a fantastic member of the community, much like Adam. She is a activist. She is an advocate. She needs very little introduction, but Gabby has just been a really vocal member of the community, especially working on policy and advocacy issues in her state of Missouri. So I would love to pass the floor over to Gabby Flores. Gabby, take it away.
Oh, that was so nice, Mary Catherine. Thank you so much.
It's
Um,
all true.
I love being here. Very thankful to be here. I'm Gabby Flores. I live with a platelet dysfunction, so I'm here as a community member. And although I do not live in a rural area, I do work on patient advocacy for Gateway Hemophilia Association in Missouri. So I'm really excited to be here talking about such an important topic. It is my pleasure to facilitate our second session today in the summit, Idea Sharing, What's Being Done to Address Gaps in Rural Access to Care. So strap in for the next 70 minutes. We're going to be hearing from 4 healthcare professionals who work for and alongside HTCs in various parts of the country about their work to expand access to care for people living with bleeding disorders in rural communities. Throughout this session, I encourage you guys to share your questions in the Q&A button. After we hear from our speakers, we get to spend the second half of this session taking questions and hearing from you guys about your ideas and what you've personally experienced as gaps to getting the care that you need with a bleeding disorder. I'm now happy to introduce today's speakers. We have Katie Foote, a licensed social worker at the Kansas City HTC, Children's Mercy Hospital. Justine Kaplan, who's the Senior Director at the Office of Public Health Initiatives, and ATHN, which is the American Thrombosis and Hemostasis Network. Allison Curry, who's a health records analyst at the Pediatric Hematology Oncology at the University of Iowa Healthcare. And last but not least, I was practicing on Google before I got on here, so I don't want to mess this name up. Rebecca Babkovich. There it was. I was practicing, I promise. And she's the director of telehealth at the Hemophilia of Georgia. So please help me welcome our first presenter. Justine is presenting on the topic of HTC interventions that she's supporting through her HRSA work, and she will be joined by her HTC partner, Allison.
Hey, thank you so much. All right. So we'll talk about using something called GIS to improve access to care. All right. Sorry, there we go. Quick funding acknowledgement. This work is funded by HRSA, and so there's that. All right, so HRSA funds regions and HTCs across the country. One of the things that HRSA does is set some objectives. There's actually many, many more, but 4 of the key objectives for this current grant cycle. It's a 5-year grant cycle. One of them, highlighted here in yellow, includes increasing 10% from baseline the number of underserved individuals who receive comprehensive care, or comp care, as we often call it, clinic visits at an HTC. And here, and I think really for this talk, anytime we talk about HTC, we're talking about the federally funded HTCs. Work shown today is identifying underserved patients as those living in a rural area or living far from an HTC. There's lots of other ways we could look at underserved as well, but that's what we'll be talking about today. All right. What's the goal of identifying underserved populations? Well, so that we can improve patient care, right? So we want to use data to help identify barriers to care so that we can do something. There's an intervention that would happen here to increase that access to care to, again, the reason I think all of us are here, which is to improve patient outcomes. All right. So what is GIS? I mentioned that acronym. We use a lot of acronyms in the health field. This one is Geographic Information Systems. And GIS is just a really fancy software that lets you take in data from lots of different places and kind of smoosh it together in meaningful ways. You can tell that smoosh is not the technical term, but that's really what it does, is it integrates and weaves in data in meaningful ways. And so that's what we're going to look at today. All right. So the background here, in what we'll be showing you, I'll show you an example from Maine, and then Allison from Iowa will hop on to talk about their work. HTCs collect a lot of data. That's wonderful. They're able to use that data for things like quality improvement projects to help decide where they, what hours they're open, how many appointments they can see, if they want to look at satellite clinics. And one of the things that HTCs are working with us on is to figure out how can they make their care more accessible. So they can run reports and extract data that they send securely. It doesn't have patient names, all of that good jazz, to help see where are their patients coming from, for example. What's their distance? All of the things that folks were talking about in that first session about commute times and drives and locations, that's the type of thing that we can take a look at. We can also then pull in things like traffic patterns, location of emergency departments, location of other types of care. We could look at things like anything that comes from the census, what languages are spoken, how often do folks have broadband internet, things like that. And so GIS lets us take in lots of types of data and put them together. And there's a lot of spatial factors to consider. And with any data, there's always lots of decisions. What diagnoses are you including? How are you looking at things? And so many awesome opportunities to think about data there. But we're going to scooch on over to talk about some of the details here. So why are HTCs and regions thinking about GIS? One is that first thing that was such a big conversation in the first session about figuring out where are patients, how far are they, how long is the commute, where could we be increasing access? Another one of those is trying to figure out, is the distance to the HTC, is that a big reason that folks are not coming or maybe aren't coming back to an HTC? And we kind of talk about that as lost to follow-up. Some folks are trying to find out where they should start a new satellite or outreach clinic. Those terms are sometimes used interchangeably. And that could be for the first time, or like you're hearing in Katie's talk, it might be an HTC that's been doing this for a very long time and has many, and maybe they're looking to expand and add another one. We have some HTCs that are working with us to identify the closest emergency department for patients. Sometimes that's just so that they know and can do referrals and get to know those folks and do training and connections like we were talking about in session one. Sometimes it's for advocacy to find out what factor products do those EDs stock. And if they don't have ones and we know there are patients nearby who need certain ones, can we advocate to change that? And there's actually 2 states that recently have had success in exactly that, getting some of the mid-size emergency departments that didn't carry factor to now stock it, which is awesome. We also have some HTCs that are using this tied to emergency preparedness. I know we heard from the Carolinas earlier. We're working with a Gulf States HTC about hurricane preparedness and how to think about things that way. All right, so we'll keep on chugging here. All right. So I'm going to give you an example from Maine, and our Maine colleagues couldn't be here today, but said that we could share. The Maine Bleeding Disorders Center was very interested in understanding the distance patients are traveling to their HTC, Maine, a very rural state. They wanted to know where patients were throughout the state, and they were really interested if distance from their centers was tied to loss to follow-up. And then they wanted to see, based on that, should we be doing something with satellites? And in their very large and very rural state, they had a goal to have all patients within an hour to the HTC. All right, so we'll go to the next slide here and take a look for an example. Oh, I think we might need to click one more time there. There we go. All right, so this is a map. I'll orient you to that for a minute, and then you'll see those here with me and then with Allison as well. So this is Maine. Hello, Maine. What you'll see is each dot here represents a zip code with 1 or more active patients. So this is not anyone's house by any means. This is a whole zip code, right? And each dot could mean 5 people. It could mean 55 people. And depending on where you are, that could vary. It could mean 155. It can be many patients. What we're seeing here is Maine, and you can see actually Maine serves some folks who are in Vermont and New Hampshire just because they're close by. They have a main clinic, Maine with no E there, their primary clinic in Scarborough, Maine, which is the Portland area. And then they also have a satellite in Bangor, Maine out here. The purple colors that you're seeing here look at what the travel time is without traffic. So this lightest purple is right here. There's a lot of dots on it, so it's a little hard to see. But this light purple band is folks who are under an hour away. This kind of medium purple is folks who are 1 to 2 hours away. And this, I don't know, eggplant color is 2 to 3 hours. This white color out here is more than 3 hours. And you can see there are some folks who are really quite far away in Maine. All right, so for Maine, looking at this was really helpful for them. And I want to draw your attention now. We've got the same map that we were just looking at, and the yellow part there, and my Zoom bar is covering it up a little bit, is showing active patients. This very similar looking map on the right that's got the blue here is showing inactive patients or patients that have been lost to follow-up. And so this was the big like, ta-da, type of moment with Maine to say, okay, do the maps look really similar or really different? And they look really, really similar. We were shocked, like the whole room of HTC staff were, one of those big gasps. We expected that we were going to see folks who were much further away, much more present on this lost to follow-up map. And that's just not what came from this data. In fact, some of our furthest away folks are active patients. So this is a really interesting finding. We've actually done this now with 4 or 5 HTCs in many different states. 4 or 5 different states. We've had the same result every single time we've done it. And if you'll click through to the next little note, that'll bring up a pop-up. So our kind of initial question of, is loss to follow-up driven by distance from the HTC? From the maps, the quick answer is no. I want to be clear, though, that doesn't mean we stop trying to increase access, right? The goal for Maine, remember, Maine had this pretty audacious goal to get everyone in Maine within an hour of an HTC, either their primary or satellite, and they are absolutely still trying to work on that. But it was really interesting to see that right now we're not seeing that as a big difference. And I think a large part of that in Maine, as well as the other states we've worked with, is a number of the programs that some of the folks from chapters were mentioning about looking at satellite and outreach clinics, but also looking at travel vouchers, telehealth, things like that. And we'll hear more about that in this next hour. But so that's just our quick Maine example. And my closing thoughts before I pass that on to Allison is just that this is an initial stage of helping HTCs and working with HTCs across the country figure out where are their patients, what would they like to, what satellites are they thinking of, or where would they like to do access? Are they thinking of mobile health? You still got to park the van somewhere. Where would that make sense? Where could this be happening? And so it's just an exciting opportunity to use data that HTCs are already collecting to figure out how they can do more. And I know you'll hear in this next hour about multiple different ways that folks are approaching this, which is so exciting. So thank you. And I will now turn it over to Allison.
Thanks, Justine. My name's Allison Curry, and I'm the data manager at the University of Iowa, the only HTC in the state of Iowa. Next slide, please. So a little bit of background on our HTC. Like I mentioned, Iowa's only has the one HTC, and unfortunately, it's located in the southeast section of the state, which leaves the entire rest of the state without coverage. We have a largely rural population and largely agrarian, and we have a large Amish population. So that creates some unique barriers both to care and creates some injury patterns and repetitive use injuries that we don't necessarily see with communities that use more modern equipment. Next slide, please. So in order to combat some of this and the access to care, we have a community nursing model where we have 3 nurses in the state divided up into sections who go out, if somebody calls and they have a bleed, a nurse can do a bleed assessment, can do an infusion, can, instruct somebody to go to the ER, can provide education, things like this, so that we can try and meet those care goals. Next slide, please. One of the things that I wanted to look into with GIS was, would it be beneficial for us to come up with a satellite location more in the northwestern part of the state or even in the central part of the state to try and ameliorate some of the travel times and difficulty getting access that we were seeing with some of our patients. Next slide, please. So here's our map. Again, this is similar to the main map with the travel times. The 1 to 2 hour, Iowa City is us. That's the University of Iowa. And then to the left, you'll see another population density area that's at the outskirts of the 1 to 2 hours. That's Des Moines. And the highway that connects those is the longest one in Iowa. It's I-80. And at the Iowa City location and Des Moines are the only places with ERs that stock factor and keep it on hand. Everywhere else in the state, until last week when we presented some of this data, whereas you could only get factor in those 2 locations if you had an emergency. We have since reached out to Waterloo and their kind of central northern part of the state, and they are talking about we're working with them to stock factor there as well, so that we don't have people travel. If somebody in Northwest Iowa has a bleed that's severe, to try and get to Des Moines, that's several hours away, even with that location in Des Moines. So we were hoping to find a location a little bit north central or even northwestern, and we were looking at Johnson to target the 2 to 3 hour folks, and then the 3+ hour folks. Next slide, please. So again, these are our travel times. That Johnston is north of Des Moines. It's kind of in the Des Moines area, but it would save quite a densely populated area for Iowa. It would save all of those folks having to travel, particularly for emergent care. Next slide, please. Again, we could target a whole lot of families when we looked at all of our travel times. And then our satellite clinics, we have one in Bettendorf, which is to the east, and Cedar Falls, which is to the west, that go once a month. But if we had a permanent clinic in the Johnston area, we could really help the north and west parts of the state. Primarily the Des Moines area is still central Iowa. So we're still, even with it being further west from Iowa City, we're still not hitting all those northwestern folks. Next slide, please. So we determined that a satellite clinic can dramatically cut down on travel time for patients. And we're working on trying to come up with and approach hospital leadership about getting a satellite clinic set up. And we can use this data. If there's anybody out there that's ever dealt with hospital admin, having a detailed map where you can say, we definitively have patients here, they travel this far, we know where factor is, we know what happens when they have an emergency. Being able to put that in front of hospital leadership is pretty invaluable. And I think that's all for me.
Hi, everybody. I'm Katie Foote. I'm the social worker at the Hemophilia Treatment Center in Kansas City. So I appreciate HFA asking me to just share what we've been doing at our center to work with outreach clinics and other ways that we've done some programming to help our more rural populations. Next slide. So a little background on our HTC. We are a lifespan center, so we provide care to patients of all ages. Our primary health facilities are here in Kansas City. Our pediatric patients are seen at Children's Mercy Hospital, and our adult patients go to University Health. Both those hospitals are basically across the street from each other, so we're basically in the same location. Our HTC covers the entire state of Kansas and then the western half of Missouri. And I realized, oh, sorry, can you go back? Sorry. My last little point here, I realized first thing this morning that my wording wasn't exactly correct. So for our outreach clinics, we see approximately 30% of our regular comprehensive visits per year in outreach. So that's about 150 comprehensive appointments seen through our outreach clinics annually. Okay, next slide. So this is a map of our outreach clinics. So the red star is obviously Kansas City, where our primary located, and then we have outreach clinics. Our pediatrics, we go to Wichita, Springfield, and Joplin, and then our adults we see in Wichita and Springfield. The white star, we used to go out to Dodge City. A few years back, we lost some contracting with the local hospital there. Our goal is to get back out there, either to Garden City, which is, they're right next to each other. So that is still a goal, to get back out there. And we started these about mid-90s, started doing outreach clinics about that time. Next slide. So for our facilities, conveniently, Children's Mercy Hospital has satellite clinics in Wichita and Joplin. So for clinic space, we're able to use that. We do, Wichita does allow us to see our adult patients in the pediatric clinic. So our adult providers come. Unfortunately, Joplin, we are not able to see adults in Joplin. And then for Springfield, Children's Mercy, our University Health doesn't have any satellite locations, so we contract with a local hospital to use their clinic space when we go out there once a year. So basically, like I think a lot of people do, our outreach services are basically the same clinic we would provide here at the main hospital. We have our medical evaluation, our nurse coordinators who do education, making sure if they need help coordinate any ongoing medical care. I, as a social worker, do the psychosocial assessment, provide resources. I actually do my contact with the patients and outreach via telehealth. So I actually stay in Kansas City and then see everybody through our telehealth platform. Our researchers often go down to help with study enrollment. And then we consistently have a physical therapist for our adult patients. Our physical therapist for our pediatrics patients we used to have that, and then there was a time that we lost that contact, and now we are building that program back up, both in our main facility and our outreach facilities, and of course, laboratory. And our most recent addition to our outreach clinics is having a representative from Midwest Hemophilia Association for our patient consumer chapter come and be able to meet with patients and families there, let them know about those support services and events to meet with everybody, just get them connected to social support. Next slide. So the successes we found is that obviously better access for patients, less travel time, less time away from work, from school, having to figure out lodging, cost of gas, and all that to come to Kansas City if they're 3 to 6 hours away from us. This does allow for us to be able to coordinate with local clinics if we're trying to set up a time to come out there and do our outreach clinic, but then also allows us to work with local dentists, other specialists, gynecologists, so we can make sure our patients are getting care closer to home as much as possible. Obviously, like I said, we provide the same level of care in our outreach clinics that if they came to the main hospital. And then for our main hospital facilities, kind of the benefit to that is we only have 2 pediatric clinics a month and 2 adult clinics a month. So we are being scheduled out and booked out pretty far in advance for our clinic space here. So having that option to see 150 patients throughout the year at our outreach clinics really frees up space in our main hospitals. Next slide. There are a few barriers because with everything, there's always some barriers. So a lot of times, so obviously our nurses, nurse practitioners, our physicians have to get credentialed at any local hospital to provide care. So that can take some time. There can be some barriers to getting that completed. A lot of times our nurse coordinator is doubling up on duties. They're not only doing their role as HTC nurse coordinator, but sometimes they're doing check-in and vitals and labs if the clinic itself can't offer that service for us. We've had some quality of lab issues with couriers and labs coming back here and not being in a quality state anymore that we can actually run and get reports from. So that's very distressing. And then of course, if the patient can't make it to the outreach appointment, if our schedules don't align with their schedule, then oftentimes they still have to come up to Kansas City, which kind of takes away that benefit of reducing their travel time and time away from home. And lately we found, especially with a lot of insurance, really needing to see a patient within a year before they will authorize medication. And if we only go out there once a year, they can't just get scheduled to the next outreach clinic. Like I've kind of mentioned, facilities, occasional contractual issues with keeping the space and the staffing that we're allowed there, and like I mentioned, the quality of labs sometimes. And then technology has actually improved over time. With COVID, we, like many people, switched to a lot of telehealth visits. And then the resources we use for outreach were a little clunky, not very user-friendly. But now we went from Microsoft Teams platform, and then we have the Kids Care Anywhere platform that helps make that a more streamlined telehealth process. Next slide. So aside from our outreach clinics, we do some ongoing programs just to continue to reach out to our patients who are distant from us. So like I said, a lot of times our clinic space and our outreach times are pretty well booked up and, not that frequent. So our nurse practitioners will have telehealth appointments with newly diagnosed patients to kind of bridge that time between diagnosis and their first comprehensive appointment. So families are not feeling they're just, left out in the cold after they get a diagnosis. So they get the educational visit, talk about treatment planning, because it can be, 3+ months before they get in for their comprehensive visit after diagnosis. Our nursing team also does virtual visits with school staff to educate them on the patient's diagnosis and making sure that they're receptive to what they need, supporting the parent and what their decisions are for the child. We also do a lot of collaborative meetings. We've had, like many people, have had patients who need higher level of residential treatment, and there's a lot of concerns with facilities accepting our patients. So we've done a lot of virtual visits, meetings to make sure our patients are getting the care they need outside of just their hemophilia care. And then we do have some good local home health, both around our Kansas City area and in our Wichita Springfield area. So families can have a nurse come out to the home if there's an injury for that kind of on-site, or just have it look at that from lay eyes on them. And a lot of times then families are able to call us. We have an email so they can send pictures if we need to see, what's going on with the injury. Next slide. Oh, and that was it. I think we have a lot of hopeful things we want to do here in the future, but hopefully some stuff we've done has been able to meet those needs of our patients and families. Thank you.
All right. Last but not least, we have Rebecca from the Hemophilia of Georgia. And she's going to be talking about how to reach our community members where they are through coordination with other HTCs and telehealth resources.
Thank you, Gab. I'll just start. So my name is Rebecca. I am with Hemophilia Georgia. I am their director of telehealth. Just a little bit of information about Hemophilia Georgia that I put up on the screen. They are a nationally and internationally recognized nonprofit organization, which is also a chapter. We provide programs and support services for people within the bleeding disorder community. We also provide nonprofit pharmacy that is available to all the bleeding disorder patients in the state of Georgia. Our chapter supports the 5 HTCs in Georgia that provide bleeding disorder care. We have 2 in Atlanta at Emory, both ped and adult. We have 2 in Augusta, and we have a Savannah HTC that is strictly pediatrics. We also have nurses and social workers that actually provide in-home nursing and social work to our clients throughout the state. So we have 7 nurses and 4 social workers that are located throughout the state that travel to the clients' homes to kind of do assessments if it's coming from the social work side, or infusion help, education in schools. Our nurses do have a list of things that they do help those families navigate in the bleeding disorder world. Next slide. So how do we get here? Where do we even come up with this whole idea of doing telehealth? So we had to recognize it was an issue. Hemophilia Georgia recognized the need for adult care in the Savannah area after the hospital system that was currently in Savannah area, which is a large metro, was no longer allowing adult clients to be treated at the pediatric HTC. I'm sure some of you are familiar with those hospitals that have those restrictions. So as a children's facility, we were not allowed to, or they were not allowed to care for the adult patients. So we noticed a lot of loss to follow-up patients that happened during that time. So when we looked at things, Hemophilia Georgia decided to look at creating an outreach center for adults in the Savannah area. So next, we kind of like, how do we reach them? How do we handle this? It is a metro, but there were no adult hematologists in the area, HTC or otherwise, that were really comfortable in caring for patients with bleeding disorders. So they kind of took a clue from the COVID struggle, and we kind of branched out and started a telehealth program. We learned that the director of the Augusta HTC, Dr. Kutlar, had actually been doing remote healthcare for the last 20 years. And so he was the first person that we paired up with to kind of move forward. So what we ended up doing is pairing with the Augusta Adult Hemophilia Treatment Center and their team, and Hemophilia Georgia supports a physical location in Savannah, Georgia once a month. And we now have what we call a hybrid outreach telehealth clinic in the Savannah area that started back in 2021. So what were the goals? What did we want to do and achieve by having this telehealth program? So we wanted to improve and expand the availability of comprehensive healthcare, increase client engagement and satisfaction, expand access to healthcare services in these underserved and rural areas, and expand and improve access to preventative services, home and community-based services, social support, and care management. So next slide. So what do we mean? This is a big words, hybrid outreach telehealth. In the hybrid model, the patient actually presents to a physical location, an office in the Savannah area. Currently, since we do not have an adult HTC there, that is considered what we call the originating site, and we provide an in-person assessment by a clinical team at that location. In-person staff connects the patient via telehealth monitor to the provider in Augusta for the visit, for the HTC visit. And then the telehealth visit continues between the provider and the patient during that time. Next slide. So this is kind of like a little bit of background. I can just kind of breeze through real quickly. This, how do we move forward with this between a chapter and we have an outreach location and then a hospital? So lots of contracting happened between Hemophilia Georgia chapter and Augusta University. We have specific telehealth consents that allow for us to have these programs and consent to care with the two locations. We had to ensure that Augusta Adult and the providers could actually bill the insurance for the telehealth services. And we had to think about any other consents that are obtained at an HTC visit. Next slide. So we kind of worked, this is before I started in my role, but they did find a location that's actually in the same building as the pediatric HTC. And we signed a lease and everything has been going well. We've been with them again since 2021 in that location. So the last 3 years. So what services do we offer? So HOG wanted to ensure that all portions of a comprehensive care visit would be provided to the patient during the hybrid outreach telehealth clinic. So the in-person staff included the director of telehealth, local outreach nurse and social worker for the patients in that area, as well as a physical therapist. The physical therapist that is contracted at that location has actually been involved with the bleeding disorder community for quite some time. So her joining the team was an invaluable asset to us. Lab collection, as we spoke to earlier, someone spoke to earlier, it can be very troublesome. And so at the time when we started, we actually worked with the hospital on site on campus that we sent patients to the their lab to have the labs collected. Next slide. Perfect. Communication equipment. So how do we do this? What do we choose? So initially, Augusta HTC already had a program working. They had been doing this, like I said, for years, and had doing this a lot with their sickle cell population. So we kind of just jumped on board. We use the WebEx platform specifically for our needs, and we have 3 large monitors that we use at the patient site. So that way it is almost like a real live person. It's not a small screen that they're on. The other thing that is imperative is that a lot of our clients that live in the rural areas that travel to the Savannah location and our now new location, they don't have internet service at their home. So just having this location that they can come to get telehealth, link up, and connection is imperative. Next slide. I was just trying to show some screens. Like, this is the large monitor we use. We also use heart and lung assessments, which happen virtually, and Wi-Fi capabilities. Next slide. So we, like I said, opened March 2021. This is a building that we were in, and that we still are in the Savannah office. It's right on the campus of Memorial Health Medical Center. Next slide. So the patients, when they come in, it's like as if they were checking in for a regular physician appointment. They come in, somebody checks them at the front desk, they provide ID and insurance, and they get all the consents to provide care there at the office, as if they were going to the Augusta HTC directly. The outreach nurse does a nursing assessment, and then we have the social worker there that is able to do her in-person assessment, and she actually remotes in with the HTC social worker with the patient in the room, so they're both on communicating with the client at the same time. So that kind of helps bridge some of those care gaps when it comes to social services. We also, like I said, we have physical therapist that is available in our location, and she has access to ultrasound. We do the labs, and like as we do community count surveillance as part of the offerings there. This is just a quick picture. We were actually showcasing our telehealth program. This is kind of what it looks like in the patient room with Dr. Kutlar from the Augusta Clinic. This in the picture on the right is Representative Buddy Carter. He is one of the Georgia U.S. representatives in Washington, D.C., and he is a huge advocate for the telehealth nationwide programs. So we had him down to kind of showcase our program and what we do in the Savannah office. Things were going so well. Next slide. We expanded the program to Perry, Georgia. This is a much more rural community and kind of hitting the lower part of Georgia state. We are there one day a month right now and have the ability to expand if we needed to. We did swap out the plan, especially once we opened the Perry location. We have changed to doing blood work. Our nurses collect and handle all the blood work themselves. It was much easier than trying to explain Roman numerals to lab techs who were trying to collect blood specimens for us. So we've just found a much easier way. We worked with LabCorp, and our staff at each site now collects their own lab work. And this is just some numbers that we've seen. Next slide. Oh, sorry, this one. So since I've taken my role in the last year and a half, we've expanded and do a lot with the research department at Augusta University. Any research that's offered at the main hospital at Augusta University is also offered to the telehealth clients. So their research associate gets on the monitor and communicates with the client, goes through all consents. And we actually added genetic counseling this past January. So she is available at both centers, and she does virtual for the distance center in Perry, and she's in person in Savannah. And she can provide and order testing recommendations for those that have not yet been tested for their mutation. And here's just some real life numbers. Next slide. Next slide. So currently we have 65 clients total. That's just the breakdown between the two locations, how many visits we've had. And on average, our patients have been lost to follow-up for about 2.5 years before we see them in our telehealth clinic. Though we've had some interesting stories. This one was, I always like to share, 22 years without care for his severe Hem A. We by chance found this gentleman. He is now being seen every 6 months and doing so much better than he was. But we've had clients that are in their 60s who don't even know what an HTC is that we've brought to follow up, or my brother comes here, can I come here? So we've really, a lot of families have really enjoyed having the local and the closeness of the travel. Next slide. Demographics wise, we see more males than females. And I think that's just because the more severe the bleeding disorder, the more apt they are to get care and not be lost to follow up. Not to say that we don't have females, we have moderate and hemophilia females that we do care for in telehealth, but this just gives you a little bit of the breakdown and where kind of our focus has been more with those clients that need more preventative medicine or prophy medications before the ones that are a little bit more able to be stable on their own. And then here is some information. This is the big thing that we were surprised in. Travel time saved, it's about 3.5 hours round trip on average for our clients that we're saving them. So that's a huge chunk of the day, like other people have mentioned. We've had great satisfaction surveys. Pretty much 99% said that they want to come back to telehealth since we've started the program. And then these are the no-show rates. This is the no-show rate for Augusta, when they have a regular HTC, Savannah, and then our peri clinic. So just showing that, you know, having them closer does make them more apt to come to their visit when they don't have the travel impairment. And I just want to, I always like to shout out to my team, because these are, I'm just the front of the dragon, if you want to, but the whole team at Augusta University is a huge part of this. We work hand in hand with their team, as well as the nurses and social workers and our whole in-person team from Hemophilia, Georgia. And that's what I have. Back to you, Gabby.
Oh, wow, this is so exciting, seeing all of this work in action and seeing how it's actually helping our community members. I just want to take a moment really quick to thank all of our presenters. You ladies were wonderful. Justine, Allison, Katie, Rebecca, you guys did great. We want to make sure that we hear about the community members' ideas for what's needed and what may be working for you guys. So make sure you guys put your Q&As in the little Q&A section. We'll give you guys a moment to do that. But before we get into those questions, I'd like to kick it off with a discussion for all of our presenters. Can you share any insights on how collaboration between HTCs and local non-HTC clinicians is helping to bridge access gaps in rural areas? What are some of the best practices for building these partnerships to better serve patients who can't get to their HTC? And then I don't know if you guys all want to answer and go in order of the panel, or if anybody just has an answer right off the bat. Whatever you guys are comfortable with.
Gabby, I'll start.
Yeah.
Our we have really tried to we've noticed an influx of patient referrals from the local area to where we have telehealth. So that's been something. We've had patients that have been seen, like I said, at some of the more hematologist offices who are now seeing referred to HTCs because more of word of mouth from patients in the, like I said, families and things like that are now, hey, I would like to go to an HTC. What is an HTC? And they're asking their hematologists more about that. It's definitely a area of improvement that we see, is getting more information to those local hematologists about the local offerings. I think somebody mentioned it earlier. It's just hard to get in the door and get the information to the appropriate person to get it noted.
Thank you for that insight, Rebecca. Anybody else have any insight on this before we go to Ray to check the Q&A?
Gabby, can you repeat the question real quick?
Yeah, of course. Can you guys share any insights on how collaboration between HTCs and local non-HTC clinicians is helping to bridge the access gap in rural areas? just giving us some best practices for building these partnerships for patients who can't reach those rural HTC or those HTCs in non-rural areas.
It just like echoes from the previous session too, just the importance of education. With education comes a level of appreciation for a patient's care and the immediacy of getting their care done quickly and just overall patient safety. I know when our nurses have connected with some of those non-HTC clinicians in the areas that we go, or even areas we don't go, but we have patients in, they're always appreciative. They want the information. So when we can find them and connect with them, they feel like they're doing the best care they can for their patient too. And I think it also think it's helpful for families because they often feel like they need to feel like they trust their provider and that their primary care provider and their especially HTC specialists are in communication. So that helps with knowing that the people surrounding them and their children are collaborating together.
That's beautiful. It's really, really important to keep in consideration. Ray, do we have any questions in our Q&A that we can answer right now?
Yes, we do. And hi, Gabby, by the way. The question is a long one. So bear with me. Here we go. Given that the data seems to indicate a lack of significant correlation between distance and loss of patient follow-up, could the existing known rural struggles be potential focal points for healthcare quality improvement, i.e. physician education, whereas loss of follow-up is a focus for healthcare process needs-based improvements, such as more tailored treatment or engagement plans?
I can answer maybe something about this, and I'm thinking Adam is tying this maybe to the main comparison map. So first of all, just the main comparison map was just looking at HTC patients, right? And so one thing that I want to point out is that there's all the folks who never made it to an HTC who could never be on either part of that map, right? And so I do think that is a big issue. And it's an issue that is hard to find out, right? Like, I think every HTC and probably other clinicians too would love to know, but who are we not seeing? But finding out who you're not seeing is a lot harder than looking at data on who you are seeing. There are a couple states that have something called an all payers claims database, which is very cool and also pretty clunky and hard to work with, but is a way to look at where folks are getting care, not at HTCs. But many states that's nearly impossible to access or they don't even have one. So aside from getting that, we just don't have that data to be looking at so well. So first, just wanted to explain that about those two maps. I do think there's a tremendous amount of other access that we can increase, right? And looking at whether someone is able to come in once a year for a comp visit versus how easily able are they to pop in if there's an acute care issue, things like this are, there's lots of other needs that aren't just that comp care visit too. So let me stop talking and pass it to others, but just wanted to clarify that about that map.
Alrighty. Anybody else want to take that question or move on to the next? Alrighty. I have my own question. As somebody who thinks we learn best from our mistakes sometimes, question for the panelists, what are some lessons learned or unexpected challenges that you've encountered in your efforts to improve rural healthcare access? How have you adapted your approaches in response to that?
I mentioned some of mine. The lab issue was huge. We don't think anything of it when we order a factor 8 or a factor 9 or a factor 11 level, but when they say take a paper order into a hospital and a front desk assistant is putting that order into the computer and they don't know how to read Roman numerals, it becomes an issue. So the labs were a big part for us and a learning experience. Like I said, we went from using the hospital, and then we ended up actually using the pediatric hemophilia treatment center that was on the couple floors below us, and they collected for a little while until we really kind of got things settled where we could do and work with LabCorp. And now it's been such an easier process for us with the Augusta team because they can order all of their labs directly through LabCorp. We get the lab orders and we can collect the labs and actually just bring them to a LabCorp site and drop them off for processing there. So it's made it much easier for us and our clients don't have to go somewhere else, because I love the paper that you give them and then they never go have it done. No offense to any patients, but I know it's a long day in the clinic, and then to add a visit to another place that you need to stop on the way home is a whole nother challenge. So we try to do everything one-stop shop for us just to make it easier on them for compliancy purposes as well as just basic care.
I think for us, our technology was just a challenge. Like I said, when we started doing some telehealth, we had these like big like robot machines that the team had to take down to the clinics to set up to have all like to connect with like me or anybody else here that they were doing some visits. But then kind of, I guess, the one thing that came out with COVID is we got a lot of better computer programs and processes to like do these telehealth visits. So that made it a lot easier to connect with the patients, because when we had the old equipment, we would run into internet access and internet lapses. And I, do recall having some very sensitive assessments and conversations with patients, and then internet starts glitching out, and it makes it for you kind of lose that momentum with trying to help that patient. So the newer programs that we're using to do our telehealth have made it much more smoother and streamlined. And then, like I said in my talk and kind of echoing with Rebecca, the lab issue has been probably the biggest thing. It was, upsetting for all of us that, got all these labs done for these patients and they get it here and they're not a viable testing anymore because they weren't transported in the appropriate way. So you have to go through the whole, like, how do you not bill somebody for something that we can't even use? And then how do we get these labs that they need to get when we try to make it so convenient for them? So those were just hurdles that we had to overcome. And thankfully the lab stuff is not in every outreach issue. That was just that one time, but it's always on the forefront of our brain to making sure that it's a successful lab draw for them and review.
I'll just add one thing, having worked with a number of HTCs across the country. I think Katie and Rebecca both spoke to, there's just a lot that goes into the satellite and outreach clinics. And a number of the HTCs that we've worked with have been really like ready to go and ready to get it going. And like in 2 months, we'll get started. And then, yeah, Katie's smiling like, no. And then the credentialing, the legal agreements, anytime lawyers are involved, it just, no offense to any lawyers in the call, but like it just takes a lot longer, right? And some folks, Allison and Iowa are a good example. When they were starting to look at their first satellite, they just immediately said, we're looking at other University of Iowa or Iowa Healthcare. Sorry, the name just changed location so that we can cut down, hopefully minimize some of the legal work and paperwork, but it's still just a lot and it takes a long time. And then trying to juggle that on top of predicting like, okay, how frequently should we go and what schedule? And like we know folks are in these locations, but do they all want to come in April every year, or do we need to go quarterly, or is it monthly, or figuring out that it's a lot of logistics to figure out, and even with a fair amount of data is still some guessing. So just props to everyone who's been doing this for a long time, to folks who are figuring out the innovative ways to look at tele and mobile and home and all of that. So yeah, really appreciate all the work everyone's doing.
Oh, thank you guys for opening up about all of these barriers you faced in your work. I'm sure it's nice for other people on the call to hear, maybe if they're trying to mimic these things, that issues that they may be facing that other people have already overcome. So I have another question, unless Ray has some in the Q&A right now. Oh,
I do have one. Thank you,
okay.
Gabby.
Yeah.
When major storms happen or have happened, and patients lose power, are those telehealth appointments rescheduled? How do you deal with those sorts of logistical issues?
I can speak to this because we were in the heart of the storm when Helene came up. Pretty much, like I said, we are working closely with Augusta University. Augusta Medical Center lost power and had no water for almost a week. So that area was pretty was a struggle. They actually had one of the nurse practitioners that was 2.5 hours away, and she was able to web in and do anything urgent. Their entire clinics, all the outpatient clinics, closed for that full week. And unfortunately, we had clinics scheduled for that time in both locations. So everybody, we had to kind of push back and get rescheduled. We had to double up on patients at our most recent clinic in Savannah, which created a very long day for the staff. But everybody was a champ kind of piecing in. But what we did was we sent an email to the HTC with the patients that were missing that visit, or we're going to have to push back either a month or two with, hey, John Smith needs refills because he is not going to have enough to get through to his next visit. So we tried to be proactive and take as much off of these clients that lived in the affected areas to know that at least they, from the provider standpoint, we did what we could do to make sure they would not be without medication. So we kind of proactively from that side took on those kinds of things for them. But their staff, not only just the clinic being affected, but the staff that worked at the clinic were significantly affected, and even going back to work had no power or water at their homes. So it was quite a challenge. I'm sure, Katie, you live in your areas. I'm sure you have storms there as well.
Yeah, probably be, same. Definitely would reschedule, but it would be for us with only going out to our outreach locations specific times of the year every year. Then it's either trying to do, we'll sometimes schedule a one-off from our clinic days to do catch up on telehealth visits if we've missed any. Trying to make it as convenient possible for the patient and family. And if they need to come up here, we work out like what are resources to help them kind of mitigate all the cost to them, what they need to do. But definitely reschedule, but it does make for some busier days when we didn't anticipate, or just some reworking, but do as best we can.
All right. Awesome. I have one last question for you ladies. My favorite question for last. Looking forward, what advancements or policy changes do you believe would have the greatest impact on closing healthcare access gaps in rural communities?
I just think for now we have telehealth still available. We still have the ability to do telehealth and be able to bill for telehealth. So I think the continued use of, I guess, COVID rules are now extended for another 2 years for now until we can get a better plan. But those seem to be working for now for us to be able to reach those patients. But I think it's really important, especially in a bleeding disorder community, that it's not, yes, rural communities are a significant challenge because of their location, but underserved areas, there may be a metro like we have in Georgia where, and Iowa is an example, big metro areas that just don't have an HTC and don't even have factor. So I think it's a combination of the rural and the underserved areas that we really need to look out for, because when people just do rural, they don't think of those care deserts that may exist in a more metro population. And that's one of my concerns when telehealth maybe does get longer term approval, that we make sure that it's not just for rural areas, but also underserved areas. So that's one of my concerns long term for the care for these patients.
Yeah, I think insurance is always kind of the hiccup, the barrier, or limits our decision making. Just with like talking with earlier with crossing state lines, some insurances won't let you go, even though if there's an HTC an hour away, but it's in a different state, whereas the one in your state is 6 hours away. And it was convenient, kind of like Rebecca was referencing, being like through COVID, that our physicians, kind of were, I guess, exempt from, they could do telehealth with people outside of their, like we had some patients in Arkansas, so we were able to see them telehealth. But then with kind of all those going away, where the licensing boards kind of took away people being able to see people out of your licensed state. So now those people have to, either go stay within their state but still be farther away from home, instead of coming to an HTC that's closer to them but in a different state. So changes in policy that maybe, let the patient choose their preference for their HTC, whether it's distance, whether it's resources, whether it's, I like that doctor and they really got it and they really worked with me, versus HTC in my state, maybe we just didn't vibe as well. So kind of let it be more patient choice than patient choice within what their insurance will allow.
Oh, great answers. Insurance is a little bit of a pain in the butt. I think we had 1 or 2 more questions in the Q&A, Ray, if you want to.
We had one more question come in. Do you see understaffed HTCs as an issue as well?
Yes.
Definitely, yes. I think that's an issue. I think part of the issue and is the title HEMOC. I think that hurts us. There are physicians that would be happy to go to school and learn how to be a hematologist. But unfortunately, it's the HEMOC that comes with it. And a lot of people don't want to do oncology. That kind of scares them or shies them away. And so you're losing a lot of providers that maybe want to be a true hematologist, but they have to spend so much time, unfortunately more than they do with hematology, learning the oncology side, that I think we are losing practitioners that would want to do this. And I think that's one of our big barriers to getting fully staffed. I mean, I think there's positions all over the country for hematologists at HTCs. I can speak that we have a couple in Georgia, I believe, but there's just not a big pool of providers to pull from because of the oncology heavy education that they have to have moving into that specialty.
Yeah, I agree. Understaffing is a big issue, and for like any HTC staff, both physicians, nurses, social workers, PT. I know at our center, our numbers are growing by the day of diagnosed patients, and it's great we're finding them and getting them diagnosed and getting them set up with care. But our clinic space and our staff available to provide the quality of care to each and every single patient is not growing at the same rate. So we're constantly kind of chasing our tail to make sure we're providing everybody the same level of care, but it gets hard sometimes.
Maybe. Well, that is all of the questions that I have. I don't know if anybody else has any more quick ones. But thank you so much to our presenters today for these wonderful presentations and for all of you staying with us to be part of this important conversation.
Gabby, thank you so much. It is time to take another break.